So today's topic is management of hemophilia, and faculty is Professor Prantar Chakrabarti, Director Hematology and BMT Army Hospital, Kolkata. Sir is also an ex-professor and head hematology in RS Medical, Kolkata. So please you carry on.
Okay, thank you. I think people have been waiting. So good evening, everyone. I know it has been a tiring day for most of you. And, if you want to learn the management of hemophilia, then you have to realize that certain bench work and technological advances has actually changed the lives of most of the hemophiliacs all over the world. So when I started my career in hematology, the stories were different. Now the stories are different. But I think as long as you're in India, you will be facing both the stories. And so you need to learn how to manage bad joints like this, who could not get proper therapy since childhood, develop deformities, cannot lead a good life, cannot continue their employment. And it's a challenge to get them back to their occupation. And on the other hand, you have these lovely children who, courtesy World Federation of Hemophilia donations and otherwise, have been put on prophylaxis, but almost 30% of them have also developed inhibitors. And so managing them, managing their inhibitors, and now you are having newer agents which not only have an extended half-life, but are known factors, right? And monoclonal antibodies, gene manipulation, and gene therapy. So in the next 40 to 45 minutes, I'll just try to give you a helicopter view of how we are trying to manage hemophilia today. And then we can discuss it further and we can all learn from each other. So today's approach would be that we will ensure that we make a correct diagnosis. I'll discuss more on it. The next step, obviously, is to educate the person with hemophilia and their family members. Next is to assess the bleeding phenotype, damage already done if we have not managed well since childhood. The concept of target joints, pseudotumors, and the impact of lifestyle. Try to prevent the complications because, we are not happy in just stopping a bleed. And that I'll discuss in much more detail. And then how do you assess your impact in terms of joint scores or functional activities like the FISH score or quality of life. So let me start with diagnosis. A fortnight ago, you had a masterclass on approach to bleeding disorders. But let me tell you, there are still patients who move about with a wrong diagnosis. There are even patients who have been labeled as combined factor 8 and factor 9 deficiency. So those are challenges, but you should realize what is the minimum workup for diagnosis wherever your practice setting is. Minimum a complete blood count, a prothrombin time, and an APTT. Now, when you interpret a prothrombin time, I would like to remind our students that do not look at INR. INR has been designed only for monitoring of oral anticoagulants, that too only vitamin K antagonists. When you interpret prothrombin time, look at the prolongation from the control value. If the lab is not giving a control value and is printing something as a range, do not accept that value because that is not correct. If APTT is prolonged as it is in the hemophilias, I'll mainly discuss hemophilia A and B today, then a correction study should be done to look at whether there is a factor deficiency or there are inhibitors. And it's very simple. Even a clinician can understand it, that when you mix it, if it is corrected, then it suggests factor deficiency because you're using a control plasma which contains all the necessary ingredients. If it is not corrected either early or late, then there are certain circulating inhibitors. And remember, the commonest inhibitors are not what the hemophiliacs acquire after getting factor 8 or rarely factor 9, but antiphospholipid antibodies also. So then comes the question of factor assay. And, we usually get one stage factor assay done. Minimum transmission-transmitted viral infections should be ruled out and should be done periodically if some people are unfortunate enough to still get FFP or cryoprecipitate, and inhibitor screening. And as I told you, as more and more children are being put on prophylactic factor 8, mainly, you should be very careful because during the first 20 exposure days and especially till the first 50 exposure days, the chances of development of inhibitor in previously unexposed patients, that is whom we call PUPs, is 30%. In any other medical discipline, people would not accept if there is such a serious adverse event in 30%. But in hemophilia, we are still accepting it, but we are trying to manage it better and ultimately get rid of it. So, is correct diagnosis difficult? It is not, because it is no rocket science, but there are a lot of pre-analytical variables. As I told you, the children have been labeled as combined factor 8 and 9 deficiency, which does not occur in the real world, because by the time the sample was transported, it did not have any factor. If you have measured factor 8 and 9, both are showing low levels. If you measure factor 5, it will show even a more low level. You measure factor 10, it will also be low. So beware of such reports. It has to be done in a properly calibrated manner with quality assurance. And I think the administrators should also realize that there should be dedicated man and woman power for that. It's not that anybody else joins the lab and starts doing it. It needs some expertise. But obviously, quality assurance in terms of internal and external is very important. And as far as clinicians are concerned, for diagnosing a person with hemophilia, remember, the eyes cannot see what the mind does not know. So even in 2022, I got a patient whose hemophilic bleeding joint was diagnosed as arthropathy, arthritis, and a needle was put in and the bleeding wouldn't stop. So I think we have to be very careful that we understand what the patient is saying, how it started, whether there is a family history and all those things. Now, those of you think that coagulation is a rocket science. As I told you, it is already not. There's also some good news from ICMR in IH. There have been latex flow based point of care devices which can diagnose severe hemophilia A, severe von Willebrand disease at the bedside. So, we are supposed to have more than 100,000 PWH in our country based on our population and based on the prevalence of the disease. We have identified only about 20 to 22,000. So where are the rest? They are there. We have not identified them. So I think you should also understand that they are now point of care. They are being manufactured and they will slowly be available. Now, the second most important thing after you diagnose it, because there are so many myths, even amongst educated people, and especially the family, you have to give a proper education. There are plenty of good videos, animated schemes. The e-learning portal of World Federation of Hemophilia gives you access. Otherwise, you can build your own videos in your vernacular, but ensure that both the person, that is the patient, and their family members understand what this disease is, so that they don't learn run from pillar to post, thinking that some miracle will cure it. Yes, it can be cured by gene therapy and other issues, even liver transplant. But those things should not be fed into their heads. They should first understand what is the best thing to do. And remember, the way you explain the X recessive inheritance, ensure that the female members are not stigmatized. I've seen so many families, the husband just walking out, blaming the poor wife, and because they say, okay, she got it, now she has to face the consequences. So as an educator, I understand you are a hematologist or a clinician, but it is your duty to see that such disasters don't occur. And these are not usually taught in the textbooks. Now, the next important concept which I'll introduce you to today is that, we usually try to classify hemophilia into mild, moderate, and severe based on factor levels. Now, the premise on which this is based is that factor levels predict the phenotype, but not in all cases. There are large inter-individual differences between the bleeding pattern, and we have not understood it very well. Though what I'll do is I will give you some predictors. Some of them are difficult to diagnose, but remember this, that there are large inter-individual differences. The major determinant is obviously factor level. In hemophilia A, studies addressing the association between factor VIII level and clinical bleeding pattern have yielded conflicting results. Can you believe it? It's the truth. If you go to clinicaltrials.gov today, you'll see now studies are being conducted to understand these differences. In hemophilia B, such studies have not yet been performed, because the general myth is that, hemophilia B, even severe hemophilia B, do not bleed that much. That also is not always true. If you look at an entire cohort, some may not bleed. Remember, every person is different, and sometimes you can't generalize things. And let me share with you something, that what determines or modifies the hemophilic bleeding phenotypes. Remember, null mutations, which do not give rise to factor at all, and non-null mutations, which lead to reduced production of factor VIII, can give rise to different bleeding phenotypes. Treatment-related complications like factor VIII inhibitors, right? So when there are factor VIII inhibitors, there's a higher risk of all types of bleeding. Now, if the patient received FFP or cryo in childhood and they were not properly tested, they can develop viral chronic liver disease, and that can lead to multiple coagulation factor deficiency, altering the phenotype. HIV leads to concomitant thrombocytopenia. That can also alter the phenotype. But there are certain genotypic characteristics which can actually lead to less bleeding. And mind you, these are not there only in review articles and textbooks. I have seen 3 patients who actually have less bleeding because they harbor a factor V laden mutation or a protein C gene mutation, protein S gene mutation, antithrombin 3 gene mutation, or a prothrombin G2021A, which is not very common in India. Even if they have an MTHFR mutation, they can have less bleeding. If they have a PI1 mutation, they can have decreased plasminogen activation, and they can have lower risk of all types of bleeding. So when you measure the factor, you get less than 1%, but they behave more like mild hemophilia. Obviously, you do not need to do all these mutations. In this masterclass, I've just highlighted that since you're not using a battery of seeing what they have, there can be different phenotypes with the same factor level. Even in ABO blood group genes, because O blood group has lower baseline factor VIII level and lower von Willebrand level, they can have more bleeding. So factor is not the only factor. It is the most important determinant, But remember, there are other players, and maybe one day we will have a chip-based thing to understand. Now, how do you assess the bleeding phenotype? I think the easiest to assess it is to take a good history and look at the bleeding records, if they have been kept. So clinical. Now, if you want to be more methodical, it has been seen that the International Society of Thrombosis Hemostasis bleeding assessment tool score actually works very well in hemophilia also. So if you see that this patient is not bleeding this much, you can use it to assess or maybe objectivize what you're seeing is true and it's not a mere perception. But it's not, indicated in all patients. But in patients who have factor 8 level or 9 level less than 1% and bleed less, you can do global coagulation assays, of which 3 have already been validated. There's a beautiful review article in ISTH, and there is now a point of care dielectric microsensor clot chip. And I have just given the reference of this as early as 2019. They have already validated it, which can, at the point of care, tell you how this patient will behave. And so how will you intervene in terms of prophylaxis and other management? So this is what is the bleeding phenotype. Now, let me now share with you WFH guidelines, because most of what I am discussing today will be based on these guidelines and sometimes from other textbooks. Now, the primary aim of care, as was mentioned, and this was way back in 2013, I call it way back because in hemophilia, 7-8 years is a massive change. The primary aim of care is to prevent and treat bleeding with the deficient clotting factor. So at that time, they said both the things, prevent and treat bleeding, right? And whenever possible, specific factor deficiency should be treated with specific factor concentrate. Because in some parts of the world, even in India, we were sometimes using FFP or cryo. The other thing which they said, and that is a managerial intervention, is people with hemophilia are best managed in a comprehensive care setting. It has been clearly proven, I'll not go through all the evidence, but it has been clearly proven that in a comprehensive care setting, even if you have more complicated patients with HIV, with target joints, the morbidity and mortality is less. So just by getting specialists of different disciplines under the same roof is a good intervention for managing hemophilia. Now, this debate, fortunately, is not there, but when I started my career in hemophilia management, and even 10 years back, this was the debate. What is our treatment goal? Is it to treat early or is it to prevent? So the treatment strategies were, when there was acute bleeding, you stop the bleeding and prevent or reduce further bleed. And that would take care of complications. But it has been clearly proven, and I think there are now thousands of citations showing that by providing on-demand care, that is after a bleed, you cannot alter the natural history. And there have been brilliant studies published, Marco Johnson et al. On musculoskeletal and all, that you are giving very good on-demand treatment, still musculoskeletal complications keep on happening. So obviously you have to stop the bleeding, but the most important priority and principle for stopping the bleeding is not to have the bleeding. I'll discuss about early treatment and appropriate dosing, but let me take you through the journey of how hemophilia management has progressed, not in terms of products which have been available, but in terms of regimen. I myself have seen this infrequent on demand. It's not regular, and it is not adequate. It can sometimes prevent life-threatening breaths. It can prevent crippling arthropathy, but still the quality of life is severely impaired. Then is frequent on demand. Yes, when the supply started improving, we also tried frequent on demand therapy. It used to prevent target joints by limiting number of joint bleeds per year in a single joint, but that was also not that good. And that's why the debate is no longer there. Then we thought of tertiary prophylaxis. Okay, this adult has damaged joints, but let us give them prophylaxis. Prophylaxis, I'll discuss the doses from the guidelines once more, but remember, they can reduce bleeding in target joints, they can improve activity levels, they can even control pain, but they cannot get you back to what you want, a pain-free life of a VWH. Now, after that, what came was irregular secondary prophylaxis. Why irregular? Because of availability. So they tried to do something when the joints were not that bad, maintain the orthopedic or radiologic joint score below an age-specific target and try to maintain a normal life with accepting certain limitations. Then came the concept of secondary prophylaxis, which we still use in many of our patients. Once, because it is very difficult to get the people diagnosed early, because they would come to tertiary care only when they have bled 2 or 3 times and the joint is not behaving well, they are referred to us. But secondary prophylaxis can enable a practically normal life, activities, and certain psychosocial development. But the ideal is primary prophylaxis, which enables a completely normal life. But the problem here is unlimited replacement therapy. Now, even the so-called developed countries are sometimes finding it difficult. Let us see. Now, I showed you what WFH said in 2013, and let me share with you now what WFH has said in 2020. Prevention of bleeding and joint damage. Okay, so they are not discussing treatment, and there are several evidences. If you look at the principles of care, they say that treatment on demand is like no treatment. Even if you have breakthrough bleeds, prompt management of bleeding episodes, including follow-up, continue physical therapy and rehabilitation. So it's not that you are preventing bleeds, so you don't need physical therapy and rehabilitation. Appropriate emergency care, because still breakthrough bleeds will occur. Appropriate pain management, management of musculoskeletal complications, management of inhibitor development. Because as I told you, during your first 50 exposure days, the chances of inhibitor development in hemophilia A is high. Management of comorbidities, regular psychosocial assessment and support as needed. This we sometimes forget. We only look at the bleeding and other things. This is very important. And for children, it is very important for the mother also. Ongoing education on treatment and self-care. That is what we call home therapy, right? For people and families living with hemophilia. So these are our principles of care. There are principles of care for European countries and others, but I think this WFH direction is a good way of understanding where we are going today. Now, if you're a bit confused as to what different types of prophylaxis are, I'll again spend 1 minute on it, because this is what you should understand if you're managing a PWH today. Primary prophylaxis means, and remember, in all the types, I will use 2 adjectives, regular and continuous. It has to be regular and it has to be continuous. Prophylaxis started in the absence of documented joint disease, determined by either physical examination or imaging studies. You don't need to do an MRI every time. And before the second clinically evident joint bleed is there, usually by 3 years of age. So this is what primary prophylaxis is. And I think this is our ultimate goal. But if you're not getting them early, then regular continuous prophylaxis initiated after 2 or more joint bleeds, but before the onset of joint disease. Mark these two terms: joint bleeds, onset of joint disease, because you know it's a vicious cycle. You bleed, there is accumulation of blood, which is absorbed, there is iron, there is neovascularization, and then it becomes a target joint. And this is usually at 3 or more years of age. That is what secondary prophylaxis is. And what is tertiary prophylaxis? People who are not fortunate enough to get prophylaxis during their childhood, for them, after the onset of documented joint disease, tertiary prophylaxis typically applies to prophylaxis commenced in adulthood. And we have shown in India that even in patients who are HIV infected and who are on tertiary prophylaxis, their quality of life and joint score can improve. Now, there is a lot of controversy, okay? I'm not going into the controversy. That's why I have specifically taken table 6.2 from the WFH guidelines, which talks of 3 types of prophylaxis: high dose prophylaxis, intermediate dose prophylaxis, and low dose prophylaxis. Mind you, earlier low dose prophylaxis was not accepted. This has now been accepted, but with a caveat, with escalation of dose intensity as needed. So what is high dose in hemophilia A? 25 to 40 units per kg every 2 days. That means thrice a week. Total consumption more than 4,000 units per kg per year. Well, hemophilia B has a longer half-life. So you start off with 40 to 60 IU twice per week, but the total requirement, if you see, it remains the same. More than 4,000 IU per kg per year. Intermediate dose prophylaxis. Now, sometimes some authors have referred this to standard prophylaxis also, because this is the standard of care in most of the countries, except in certain European nations. 15 to 25 IU, same, 3 days per week. Now, this was every 2 days. So if you look at 14 days, they would not get 6 doses, they would get 7 doses. Here, they are getting 6 doses. That is the difference in frequency, but their total requirement is from 1,500 to 4,000 IU per kg per year. Similarly, for factor 9, but you do not decrease the frequency. It is twice per week, 2,000 to 4,000. Mind you, these are all for standard half-life factors. Now in India, extended half-life factors, both factor 8 and factor 9 are already available. I'm not going into the details. But what most of us are following is 10 to 15 IU per kg, even 2 days per week. And the same dose, 10 to 15 IU per kg, 2 days per week for factor 9, where the total requirement is not more than 1,500 IU per kg per year. So if you take, say, 10 rupee per unit for a, say, child of 20 kgs, so it comes to 3 lakh rupees per year. Very low dose prophylaxis has also been tried. It still reduces the annual bleeding rate, ABR, but it is not as effective. And how do we know it is effective? I'll tell you about how we assess it. But before that, let me tell you, because these products are, some of them are already available in India, and some of them were available as WFH donations. So Eloctate was available for some time. Alprolix was also available. These are the long-acting factors. Now, remember one thing, except one, which is still in clinical trial. Extended half-life factor 8 does not have that much of a half-life. It is only 1.4 to 1.6 times the standard half-life. But if you look at hemophilia B, look at the mean terminal half-life, 102 hours. Okay, that means almost 5 days. So they have done better, and that's why they can be used even once a week. Now, what are the benefits? The benefits are twofold. You can all go through the guidelines to read it. One is lower infusion frequency, so fewer clinic visits or home care visits, less burdensome infusion schedules, less need for continuous access device, venous, and increase uptake of prophylaxis. Acceptability is more, but that is not the only story. The other story is benefits of higher factor trough levels. Because of their long half-life, it is more effective. And if you look at factor 9, extended half-life, even at the lowest level, trough level, it is 4%. So the area under the curve is more, but obviously the problem is, we all understand, is the cost, and who will bear the cost and how we will do it. Now, the other question which we need to understand today, if we are giving prophylaxis to our PWH, is, does one size fit all? Let me discuss both sides of the coin. These are the advantages. Advantages are, if you're giving high dose, like, I told you about 40 units or more every 2 days, it ensures that patients with hemophilia will have measurable factor VIII 9 levels above 1%. All individuals receive enough treatment and achieves lowest joint bleeding rates. It offers benefits for very active individuals. But you have to remember that if you go to low dose, then it can reduce the incidence of bleeding by around 80%. And it can reduce the bleeding rate to less than 3, but not to 0. But frankly speaking, this is the least expensive of the fixed regimens. So if you are using a fixed dose of, say, 10 to 15, then you can give it to more children, more adults. The only problem here is unknown long-term effect on musculoskeletal deformities, which are likely worse in comparison to intermediate dose or high dose. But if you are giving high dose and one size fits all, imagine the frequency and the number of factors you need. So one size fit all doesn't work. The simplest thing which can work is you escalate or de-escalate it depending on the bleeds. For that, you have to well document what is happening to the individual patient and do it. Something else can help you, and this is not Prashant Kishore, this is pharmacokinetics, right? So PK can help you because every person's system handles the factor differently. And now they are apps. There is something on the open source domain also from Canada, where if you have 3 levels, you can put it in and you can get it the area under the curve and the frequency, what is needed. So obviously pharmacokinetics can help, but it is tedious and difficult. This was all about prophylaxis. Now let me come to the management of acute bleeds. I think most of you know, but I'll quickly revise it because acute bleeds should be treated as quickly as possible. If you have a doubt, treat it. Patients usually recognize early symptoms just like aura of seizures, and if they say they think they have a bleed, believe in them rather than having a bleed and more joint damage. Assessment should be performed to identify the site of bleeding and give an appropriate dose. Giving something which is less does not help. In severe bleeding episodes that are potentially life-threatening, especially which can block the airway like head, neck, and GI tract, treatment with factors should be initiated immediately. even before diagnostic assessment is completed, because you have to save the life. I think all of you already know about price, protecting the limb through a splint, giving rest, ice, that too intermittently, not direct, compression above it so that there is less blood flow. And if it's in the lower and upper limbs, then you elevate it. But remember, price is a first aid measure. Price will not achieve the outcome unless you give it factors. DDAVP may be used in mild to moderate hemophilia, but you know, the IV preparation is not available here, and whatever is available as a nasal spray is far suboptimal because it is for a different indication available in India. It should be within the golden hour or at least 2 hours. So usually the target is in minor bleed, 40 to 50% of normal. In surgery and life-threatening bleeding, 90 to 100%. And remember, half-life of factor 8 is 8 to 12 hours. Half-life of factor 9 is 24 hours. So adequate dosing. Mind you, this I've selected not from the original WFH guidelines, but from the guidelines within it, which talk about countries where there is significant resource constraint. Joint bleeds, how many days? 1 to 2 days. Try to achieve a level of at least 20 if you can't achieve 40. For superficial muscle, 20 to 20. For initial ulcer bleed or nerve vessel injury, 30, 15 to 30 levels. But give it more, 3 to 5 days. If there is neurovascular compromise with deep muscle bleed, fasciotomy may be required, and there you have to maintain the level for 5 to 7 days. All of you know this calculation. So if you want to raise it to a definite level, you know 1 unit per kg raises it by 2% in terms of factor 8 and 1% because it goes to the endothelium in terms of factor 9. Now, there are certain other things which may not be there in the textbooks. Identity card. You as a caregiver has to take responsibility so that they have easily accessible identification if they go to an emergency. If they have become unconscious because of an intracerebral bleed, the people there know. And even if they have an inhibitor, they know what to do. You know, testing for DDAVP response is adequate. Remember, veins are their lifeline. So use 23 or 25 gauge butterfly. We do not advocate central venous access here in India for so many reasons. Adjuncting therapy, especially tranexamic acid. Orally, locally on the gums, spraying it during surgery. We have used it in all levels. Standard dose in adults is for oral 1000 milligram 3 times daily. Now, inhibitor management is a different story. The most important thing I told you, if you're putting someone on prophylaxis, other than when you suspect if it is not working, for the first 50 days, please check it at least once or twice, because if they bleed and you give the factor and it doesn't work, it might be too late. Otherwise, you can screen it once in a year or prior to surgery. Home therapy is essential, whether even if the particular government believes that you cannot give prophylaxis, even on-demand therapy, if it has to be given early, it has to be given at home, but there are issues there. So basically, early treatment, immediate access leads to decreased pain, fitness and physical activity. You know, this ESI reimbursed patients, these people have been receiving factors for so many years, but they are reluctant to do physical activities. Sometimes they have very bad joints. So physiotherapy not only promotes strong muscles, it develops balance and coordination, and it also decreases the need for factor. But you have to monitor because you are using expensive products. So regular monitoring of the health status and assessment of outcomes are key components of the care. And you have to look not only at survival, but also at cost, visits, hospital admission, unemployment, joint status, disability. Evidence is slowly coming for pain relief. Ideally, paracetamol plus tramadol, codeine, selective COX-2 inhibitors if these are not working, but no aspirin or NSAIDs. I think all of you know this. Surgery and invasive procedures. Let me tell you, if someone is also on non-factor prophylaxis like emicizumab, they have a chance of bleeding. So they will need adequate levels of factor during surgery. Those who are on prophylaxis with either standard half-life or extended half-life factors, they will need more factors. But even joint replacements can be done. I'm not going into the details. Good oral hygiene is essential. Otherwise, children also having poor oral hygiene bleed a lot from their gums. Remember that there are certain genetically modifiable risk factors, non-modifiable, that is genetic factors, and modifiable. So what are the genetic factors? Type of the mutation. If it's a null mutation, more chance. Ethnic and racial mismatch is there. Factor 8 haplotype variation. If a family member has inhibitor, and inheritance of non-O blood group also leads to more inhibitors. Non-genetic immune modulators are if the factors have been used for the first time during accident, where you use it a lot, or during a major surgery when the body's immune system is already primed, or during vaccination. Age at onset of therapy, we can all discuss it once I complete this class. Modality, continuous infusions have a higher chance. Intensity and prophylaxis debatable. Type of product, I think the CPET study has raised a hornet's nest, but more studies are required. Now, let me be a bit more futuristic as I come to the end of my talk. We started a bit late. Anyway, we are now developing hepatic gene transfer, right, to develop tolerance to inhibitors, because I told you 30% of pups will develop it. Polyclonal Tregs, gene-modified B cells, B-cell depletion with rituximab. I think some of us already have example, and we are trying oral tolerance. This will all come in future. There's a beautiful article in Frontiers in Research. If you want, you can see how we are trying to manipulate the Treg cells to develop tolerance to inhibitors. Till this arrive, immune tolerance induction, either by using high dose factor or porcine factor and immunosuppressants, is the only way to get rid of inhibitors. Now, after all this I've discussed, if a PWH with hemophilia comes to you today, you'll tell me, sir, what will I do? What you will do will depend on certain things. Understand the bleeding phenotype of the person, look at the joint status of the person, try to understand the treatment adherence, and if the person has already been prescribed, is the patient compliant? What is your venous access, and what lifestyle does the patient lead? Depending on those things, here is an algorithm. I've given the full reference. This was presented as an abstract. It says hemophilia treatment in 2021, choosing the optimal treatment, and whether the ABR, bleeding rate, is more than 2 or less than 2 total bleeds per month. They all are converging where? They are all converging as to what is the joint status. If the joints are not involved, consider to switch to AHL or non-factor if it is available. If the ABR is less than 2, you continue your current treatment. Whatever prophylaxis you're giving, even if you're giving low dose, continue with it. But if the joints have been damaged and there are target joints, you have to intensify the standard half-life factor or switch to extended half-life with similar frequency, provided that the patient is compliant and you have good venous access. If the patient is sedentary, not good compliant, don't consider intensifying the dose with SHL. Consider switching to extended half-life or non-factor replacement, which is very difficult to do in India. But I think as more and more products come available, this is a good algorithm. If I talk of management of hemophilia, and if I talk of only the patient, my work is totally incomplete. Remember, you have to manage the family. You have to tell them what carrier detection is, what prenatal diagnosis is. You have to manage the society where there is so much stigmatization. You have to manage the government, which sometimes feel, this is too expensive. So on demand, something is enough. You have to manage the industry so that they reduce the prices. And you have to manage the patient organizations who can work as advocates and also can ensure compliance and optimization of outcomes. Now, as far as non-factor therapy is concerned, any hemophilia update you go to, this is what is discussed. One product is already available in India, emicizumab, which is an anti-factor 9, factor 10 antibody. So it can bypass factor 8 deficiency. First, it was approved for people with inhibitors. It has been subsequently approved of those without inhibitors, but cost is the limiting toxicity. The other, which is into phase 3 trials, is the anti-TFPI antibody called concizumab. Fitusiran, it was temporarily stopped. Again, phase 3 trials have started where, it has a small inhibitory RNA so that it can ultimately lead to less of antithrombin and less bleeding. Gene therapy, I'll just discuss this study because this has been just published. Most of you must have seen it. 134 adult men with severe hemophilia A, and this is what it has achieved. After infusion, 98, single infusion, mind you, 98.6% reduction in infusions, bleeding episodes, 83.8%. But here is the red herring, 16.4% had serious adverse events. So we need to learn more about it. But if you want to manage, if you're already managing, and if you want to manage a PWH, you cannot only be a healthcare provider. You have to be a patient advocate, activist, teacher, genetic counselor, researcher, key opinion leader, policymaker, but you are not alone. This is a tweet from Ministry of Health, which says that the government is also committed because, out-of-pocket management of hemophilia is very difficult. I think we have had a helicopter view of management of hemophilia. Now we can learn from each other through questions. And I think there is something in the chat box. Okay.
Good evening, sir. Thank you. Yes,
good
sir.
Evening. Good evening.
Good evening, sir.
Yeah.
That was an awesome lecture, sir. It was really, sir, we always wait for your talks. They are extremely informative and they are wonderful slides as well. So thank you so much, sir, for that insight and on aspects which we don't usually learn from textbooks and from our normal didactic teaching. So this is a really real eye-opener for me also. A lot of things were new for me as well. Sir, I have a question. Sir, have you, are you using emicizumab right now in your practice?
Yeah, very good question. I had used it in a phase 3 clinical trial in 2 patients with inhibitors. Yes, and right now, one of my patients has just gone on maintenance prophylaxis. Okay. Right, this patient has a very high titer of inhibitors, but a child. And the good thing is that I could convince the insurance company to bear the cost. So
That
insurance
is
companies
really
never
good.
reimburse it.
Yes, sir.
This,
Yes, sir.
yeah. So
That is really good.
yeah. So this is, the child is into his second month of emicizumab. He has not had a single bleed. I don't know
Right.
what will happen in future, because we have to see it. And we always talk of ITI, but in the clinical trial, I think the data has already been published. The two patients from whom I learned, their inhibitor levels actually went down. And that is logical, because they were not exposed to factor VIII. They were on it for 2 years, along with, post-trial exposure, post-trial access. So it actually is not only a novel way of managing, but I think it's a lifeline for those with inhibitors.
And
the
it
only
does not.
problem is the cost.
Yes, sir. How much is
Recently,
the
the cost
cost?
has been reduced to some extent, but I think it needs to be reduced further. And the other problem is regarding some of the thrombotic episodes, and that there was these thrombotic events there. The data in the public domain is no longer being updated. So I do not know if anyone is using it. I would encourage them to document whatever is happening so that we can share, because post-trial licensing and access is a better way of learning what happens in the real world.
And so what is the cost right now, sir, of monthly prophylaxis with emicizumab?
Yeah, so let me tell you. So if you give it to a child who is around 20 kg, and if you use, say, 60 units, right? 60 every week for the first 4 weeks, and then you can use it every 2 weeks or 3 weeks.
3 weeks.
Yeah.
Yes.
So the cost comes to around, for the first month, 4 doses, it comes to around 4 lakh rupees. Okay. That is for a 20 kg child, remember. But they are giving certain free, I think they are giving 2 or 3 for every purchased unit. So ultimately the cost would be around 3 times that of standard half-life low dose prophylaxis, but way less than if you have to give prophylaxis with recombinant factors.
Proper, yes, full dose prophylaxis.
Yes, full dose prophylaxis.
Yes, another thing is it does not require venous access. That is another major advantage.
Yes, absolutely.
Babies, for babies and for
yeah. So the mothers can give it. That is what we have
home.
done. During trial, we didn't have that permission, but now
Yes.
We have it.
Sir, there is a question. Somebody has posted a question about
radiation
role of
synovectomy.
radiation synovectomy. Yes.
Yes, it does have a role. So nuclear scientists have continuously done it. It does have a role, and it helps the people. But post synovectomy, if proper physiotherapy is not done, then the joint improvement is not that good. So remember, whatever you do, you can do medical synovectomy also, right? You can do radiation synovectomy also, but remember that you have to do proper physiotherapy after that. And if necessary, if there are bleeds during that intensive physiotherapy, you have to administer factors. So that is, it's a team effort. I did not show you, the people who are to be there in comprehensive care, because I think if you give more and more prophylaxis, comprehensive care requirement will be less, but it will never be zero. So you need to have a physiotherapist. You need to have a department which will go in for rehabilitation. You need to have an orthopedician. And
who is sensitized. Yes.
Absolutely. Who are sensitized. Yes.
Who are sensitized. So the physiotherapist and the orthopedics should be sensitized to these problems.
Yes.
And should be well versed with these issues.
Yes.
Sir, there is another question, related question, that how to mobilize a patient who has a target joint. Target joint,
yeah. The first is to see why it is a target joint, right? There may be certain other factors like, it's a vicious cycle, as I told you. The joint gets bleed and then they do not use it, the muscles get weak. So there are certain remediable factors. Sometimes they change the axis. Sometimes they do even, plaster casts so that you can go in for managing that particular target joint and then go on to tertiary prophylaxis for a limited period of time. That is the way you can take care of the target joint. If it's hopeless, then you have to go in for joint replacement.
Yes, sir. And there is another question also, sir, about when to test for levels post FFP transfusion.
See, I would not suggest to give FFP. Please,
Yes,
please.
sir.
If you have to give, I do not, say that recombinant is better than plasma derived or plasma derived is better than. But if you are using a plasma derived, see whether at least 2 methods of viral inactivation have been done. They are specified in the WFH guidelines like nanofiltration and heat inactivation, solvent detergent method. So, but please don't give FFP.
Yes, sir.
I would not. But if you're giving factor, you can do it after 1 hour, right? If you have to look at the increment, you can do it after 6 hours also. Like I told you, if you have to use a PK-based calculation of how much to give, then there are definite set time points. You just take 3 of those time points, put it into the app, software, and you will get the area under the cuff. Yeah, the right. Software will do it for you.
Right, sir. Sir, this recent WFH has also some very interesting scenarios, like how to manage a patient or how to manage a patient living with hemophilia who has had a who has had an acute MI.
Yeah.
So giving antiplatelets, anticoagulants, or maybe let's say has had a DVT. So giving antiplatelets, anticoagulants, and giving factors. So, sir, do you have some experience with this kind of a situation?
I managed it only once. That patient could afford factors, out of pocket. So I've done that. Otherwise, you're talking of AMI. Look at what we did in COVID. When the hemophiliacs developed COVID, I did not give anticoagulants. I told them they're naturally anticoagulated. So let us try, because where will you get so much of factors, right? But in certain cases, if it was bad, even in hemophiliacs, we have used antiplatelets with strict monitoring for a few days. Yeah, small duration, just to ensure that there is not much of micro thrombi in the pulmonary vasculature, which actually leads to deterioration of COVID. Right. See, I'll tell you, that's why I told you what is the priority for India. Priority for India, these are the WFH has given it. Why? Because the developed countries, they do not think of prophylaxis now, right? They are thinking of terms of gene therapy or extended half-life factors. Now here, even doing the correct diagnosis and putting someone on prophylaxis is a challenge.
That is also a challenge.
So once we achieve it, then we'll think of AMI and stroke and other things.
That is true. That is true, sir.
Yeah.
Yes, sir. I guess there are no more questions from the audience.
Yeah.
So yes, so it was a really wonderful session. Thank you again so much for your insight on the topic, on the different aspects of this topic, which you covered very nicely. Thank you so much, sir.
Thank you. My pleasure.
Thank you very much.
Thank you, sir. Thank you, Shaurya sir. Thank you, Prantar sir.
Thanks the organizers. Thank you.